Good evening, everyone. And today we are going to talk something about approach to traumatic cardiac arrest. So, last time we talked something about the general pitfalls about managing the polytrauma patient. So, today we are going to focus purely on the management of patients with polytrauma who are presenting in cardiac arrest. So, if there is nothing that you take away from this lecture, the only thing that I want people to understand is that traumatic cardiac arrest is extremely different from how you approach a medical cardiac arrest. The causes are different, the approach to the treatment is different, the things that we prioritize is very different. So, unfortunately, this is not appreciated by a number of people. So, if you look at certain acute life support courses that are provided in India, they assume that approach to traumatic cardiac arrest is exactly the same as you approach a medical cardiac arrest, which is absolutely wrong. And this is again one of the reasons why the general teaching of the care of trauma patients in India is extremely poor. In fact, you have entire books that are written on this topic from Indian authors who pretend that the traumatic cardiac arrest is exactly the same as any other medical cause of cardiac arrest, which is wrong, and you won't actually save any kind of patient if you approach it that way. So, what exactly is different? So, before we go into that, one thing you have to understand is that there is a very narrow window for actually saving these kinds of patients, and once you cross that window, there isn't much that you can actually do. So we have to be aware of when to actually withhold resuscitation, because this is also important, because if you're working in a high flow center like I am, so if you're providing 30-40 minutes CPR to each and every patient who walks in through the door, then you are going to drain your resources very, very quickly. So you have to realize in which patients you have to proceed with full resuscitation, and in which patients resuscitation is a point in it's an exercise in futility. So trauma incompatible with survival, decapitation, hemicorporectomy, exposed brain matter. So in these kind of severe trauma cases, the patient is in cardiac arrest, then the patient is not going to survive, and you shouldn't bother with CPR in those kind of cases. No sense of life in the preceding 15 minutes. Sense of life will get into a little bit later on, but basically kind of difficult in the Indian scenario. This is taken from a UK guideline, but kind of difficult to tell in the Indian scenario exactly when the onset of cardiac arrest was, and when the last signs of life were. And but you can look for signs of prolonged cardiac arrest. So if the patient is having lividity or rigor mortis, then there is not much point in actually going for resuscitation in that kind of case. And another thing that I had not mentioned here is that if you're dealing with a mass casualty scenario and you are receiving like 80, 90, 100 patients, then that is probably not the time to start doing CPR on patients. So if the patient has gone into cardiac arrest, then you have to trash them as code black only. So those in a mass casualty situation, then you have to let go of the patients who are actually presenting with cardiac arrest. They are because if you go after them and drain your resources in that kind of patients, then you will end up killing a lot of patients who are actually salvageable. So that is something that that should not happen, and that is something that you have to know in the trauma scenario, because we do get mass casualty scenarios coming in from the time to time. So, what are the main causes of traumatic cardiac arrest? So, it can be mainly five possibilities. You have a severe head injury leading to cardiac arrest, extreme blood loss leading to cardiac arrest, tension pneumothorax, cardiac tamponade, and upper airway obstruction. So, of these, severe head injury, there's nothing you can do. So, the severe head injury leading to cardiac arrest, that patient is not going to come back, unfortunately. So what we are focusing on are on the other causes, and trying to see if we can do anything that can help the patient there. So traumatic cardiac arrest, if the period from the arrest and you starting your resuscitation efforts becomes more than 10 minutes, then the likelihood of survival decreases rapidly. So the best outcomes that occur when the victim is identified either in the peri-arrest scenario, and or immediately after arrest, so that you can take measures to actually prevent arrest or rapidly reverse it. So this is the ATLS algorithm for traumatic cardiac arrest. So this can seem a little bit intimidating, but we'll go through each and every part of this algorithm to make it very, very simple and clear about what they're actually trying to say with this algorithm. So basically, you're looking at the reversible causes of traumatic cardiac arrest. So one thing is hypoxemia. So if you compare and contrast with how it is from for medical cardiac arrest, generally in medical cardiac arrest we don't focus much on intubation. So it's well, it depends on your sender and all, but in general, intubation is not considered a priority in medical cardiac arrest unless you are suspecting that the patient had a cardiac arrest purely due to hypoxemia. So in that case, you are going to intubate right away. Otherwise, generally for an MI patient, intubating is not a priority for that patient. So, but in a trauma patient, you are going to go for a definitive airway straight away, so that you are taking a hypoxemia out of the equation, basically. Ideally, this should be done with C-spine immobilization in place, and you do endotracheal intubation with manual inline stabilization. You do not do endotracheal intubation with the C collar in place. So, can anyone tell me why we do not like to intubate patients with a C collar in place? You can unmute yourself and sell it, or you can just type it out in the chat box. Why do we not intubate the trauma patient with the C collar in place? Why do we go for manual inline stabilization? Everybody has written something. No, nothing about venous congestion. S- See, there have been cadaveric studies, and they have shown that there is actually less cervical spine movement if you do intubation with Mills than if you try to do intubation with a C collar in place. So that is why it is recommended that you actually do intubation by removing the C collar and providing manual inline stabilization, and then proceeding with the intubation. So it is basically cadaveric studies, not great evidence per se, but that is generally why we do not try to intubate with the C collar in place. We have to remove loosen the C collar, and you give Mills, then you intubate, then you put the C collar back on. So that is how it's done. And of course, in trauma patients, you just avoid nasopharyngeal airways as much as possible. If the patient is having distorted airway, then you might have to think about a surgical airway for the patient. If you are not an experienced provider for some reason, and you're not in a tertiary care hospital, and you're not able to intubate for some reason, you're not having equipment, you don't have suction or something, then one thing you can try is you can put an LMA in, and that might be good enough in a lot of patients to achieve adequate oxygenation. So that is again something that you can consider depending on the kind of scenario that you find yourself working in. So that is now when I'm talking about this intervention, I'm not assuming that we are doing one of these interventions at one time, because we are assuming that you have multiple providers available and you're doing most of these things simultaneously, which is what usually happens in our trauma center if a patient with traumatic cardiac arrest arrives. But suppose you're in a situation where you are alone, or maybe the number of providers is actually very less, then intubation would not be the priority depending on the case. So general priority is not going to be intubation will be done, but you might want to delay that in place of some of the other things that are on this list. So hypovolemia or blood loss. So what you can do is direct compression of any obvious bleeding site. If there is any obvious major bleeding that you can see immediately, you could try to deal with that straight away. I- if you have any signs of pelvic instability, you can put a pelvic binder, or in any case of polytrauma, it might be a good idea just put in a binder right away and remove it later on if you actually rule out a fracture. Because anyway, in a cardiac arrest scenario, there is no point waiting to confirm whether there is a pelvic injury or not. Better to just put the pelvic binder right away if possible, and then decide later on what to do. And if you have any long bone injuries, try to lengthen the displaced fragments to try to reduce the bleeding if possible. So those are some of the things you can try. Now, ideally, the resuscitation fluid for a trauma patient is going to be blood products. It is not IV fluids, and it is definitely not inotropes or vasopressors. Because most of the trauma patients are already going to be having severe catecholamine surge, and severely they are going to be severely vasoconstricted anyway. So giving some kind of vasoconstrictor like noradrenaline is completely pointless and useless, because that is not the predominant problem in these kind of patients, and you're not actually fixing anything by trying to give more of that. So what you need to give is give blood products. Now the question here is that whether you actually want to give blood products, because blood products is an essential commodity, and most places don't have unlimited supplies of blood products. So if a patient in cardiac arrest, in general traumatic cardiac arrest, the survival rate is very bad. So you have to be little bit choosy about who to actually start pumping in blood products on. But in general, you have the best resuscitation fluids is blood products. If not available, you can give about 1 liter of IV fluids, and generally Ringer lactate would be preferable to normal saline in most cases. Now, in a traumatic cardiac arrest, you do not wait to rule out pneumothorax clinically. You do not look at the trachea. You do not auscultate the lungs. You do not put the ultrasound probe on the chest. You do not do any of that. You straight away go for decompression of both the chest. Now, if you have a penetrating thoracic trauma like a gunshot wound or a stab injury to one side of the thorax, obviously you're going to put a chest tube directly on that side. If you have a polytrauma case, you're going to decompress both sides. You can either do finger thoracostomy or you can put chest tubes. Either way, the point is to decompress both of the chest. So in a cardiac arrest scenario, you do not wait to try and see if there is pneumothorax, hemothorax or not. You just put it, you decompress first, ask questions later. So this is the big difference from other scenarios. You straight away you decompress both chests. The absolute worst kind of resuscitation of trauma patient that I've seen is when people have manage it like a medical cardiac arrest, and like 20 minutes later they find out the patient had bilateral pneumothorax. So by that point there is no point doing anything, because patient is already dead. So you have to do this decompress both sides of the chest within 2 minutes. So that is the only chance that the patient has of any kind of meaningful survival. Now for cardiac tamponade. So after you do this, intubate by, bilateral chest tubes, and if possible, you will obviously have someone else to do this for you. Is to look for pericardial effusion and tamponade. So what is the essential thing that you want to look for on focus with these patients is to look for fluid around the heart. Now, if there is pericardial effusion, that means there is bleeding into the pericardium in the case of trauma. Then the solution is a thoracotomy. It is not pericardiocentesis. Now, you might find yourself in a situation where you are not trained or enough to do a thoracotomy, or you are in a center where there is no OT. In that case, it is reasonable to proceed with needle pericardiocentesis. Sometimes people get away with needle pericardiocentesis in these kind of patients when the bleeding has already stopped, a clot has already formed, the bleeding has already stopped, and the patient is still having tamponade physiology. In that case, you can get away with just doing needle pericardiocentesis and the patient will improve. Most of the time, that is not what happens. If you remove blood through the needle, it will just keep on forming. So the solution is not just needle pericardiocentesis. The solution is ED thoracotomy. If you find effusion around the heart on ultrasound. Now, I've told you this. When you are evaluating these patients, you have started CPR, you have intubated the patient, you started on IV fluids, you decompress both sides of the chest, you put your ultrasound probe, there is no pericardial effusion, there is no cardiac activity, you call off the code. You do not continue CPR for 20 minutes. In these cases, patients are not going to have any meaningful survival. If you give enough ADF for 4 5 doses, sometimes the patient's heart can start beating again, but there is absolutely no chance of neurological survival. So in these kinds of cases, you have to be a little bit more pragmatic in when you call off the code. So there is not much point in case of blunt trauma, and we'll get into the reasons why that is the case a little bit later on. In blunt trauma, without any hospital or pre-hospital signs of life, you have done the initial steps, no cardiac activity, no tamponade, you call off the code. There is not much point in continuing the code further. Now, another huge difference between medical cardiac arrest and traumatic cardiac arrest. Role of ATR, there is no role. In fact, there are retrospective studies. I know retrospective observational studies not great evidence, but still retrospective studies that showed that patients who have not got an ADR in traumatic cardiac arrest have tended to do better than those who had gotten ADR in traumatic cardiac arrest. So mainly, as I said again, these patients are not going to get better because you're giving ADR. This is not an ADR deficiency problem. That doesn't going help much in the scenario. Only exception is if the patient is having neurogenic shock. So in case of a neurogenic shock that is leading to cardiac arrest, then ADR might be useful. Now, but in most of these cases, that is not the case. So in general, ADR is not a very useful option in traumatic cardiac arrest. So again, as we'll review this again, standard ACLS is not very useful in the trauma patient. So chest compressions can make life-saving procedures more difficult, and in general, if the patient is completely bled out, chest compressions by itself are not very useful in actually generating adequate cardiac output. That is one of the reasons why in certain cases of having actually penetrating neck trauma or penetrating extremity trauma, sometimes even then there are some indications, some centers where they might do an ED thoracotomy even in those patients, because an open cardiac massage would be much more effective in generating an adequate cardiac output in those kinds of situations compared to just not normal chest compressions. ADR is not useful in most of the situations, but if you are somehow suspecting that a patient is having some kind of medical cause of cardiac arrest for some reason, then you do proceed with standard ACLS. So, what are some of the clues? Well, one thing is that if the patient is having, initial rhythm is ventricular fibrillation or ventricular tachycardia, that could be a medical cause of cardiac arrest, because generally in trauma, the initial rhythm is either going to be asystole or PEA. So if you have VTVF, then that might be a scenario where something else is going on. It's not just the trauma, and you also correlate with the history, because if the patient has fell off the bed or something, or fell off 2 stairs, and the patient is persisted in cardiac arrest, there is a high likelihood that there is something else going on other than the trauma. So always clinical correlation is required. So this is not just my opinion. So European Resuscitation Council 2021, they have stated in the CPR and special scenarios section in their guideline that treating the reversible causes should take priority over chest compression. There is no guideline that says that you should not do chest compression, but chest compressions should not delay life-saving interventions, which is the opposite of what happens in a medical cardiac arrest, when we generally say that we shouldn't stop chest compressions at all. And they've clearly said that don't try to pump an empty heart. So because just doing chest compression generally doesn't do much good in these kinds of patients. So again, I've also referred the ERC 2021 algorithm. They go through some of the main same things that we have mentioned here. So what they mentioned is look for hypoxemia, hypovolemia, tension pneumothorax, and trombone. These are the main things that you are trying to reverse in the traumatic cardiac arrest. So you address the reversible causes, control external hemorrhage, secure the airway, bilateral chest decompression, pelvic splinting, and blood products. So these are what you generally try to do. Plus or minus, then you think about resuscitative thoracotomy if it is possible at your center. So again, little bit similar, but ERC has compared to ATLS, there is a greater emphasis of not pushing the chest compression. Whereas if you're looking at the ACL guideline, they do recommend chest compression and ADR and all. So they still recommend that. But ERC has not given much role for that comparatively. So again, re-emphasizing, first priority is always going to be to secure the definitive airway, bilateral chest decompression, and focus to look for any pericardial effusion. So this is the same thing that has been suggested by ATLS. So in within the first 2 minutes, this is what should happen. Start CPR, secure the airway, secure an IV line or an IO line if you're not able to get an IV line in. IV fluids and ADR as recommended by them. Sometimes if you might get ROSC early on, in that case, it's great, congratulations. But most of them that doesn't happen. Then you go for chest decompression. Generally, this should be happening simultaneously. And if that also doesn't achieve drugs, then they move into whether or not you should do a thoracotomy or not. So again, blood traumatic cardiac arrest, essential thing that you should be doing in every patient's intubation, bilateral chest decompression, pelvic binder, splint any long bone fractures, fluids or blood products. So that is the initial steps. Next is the question of whether or not to proceed with ED thoracotomy. So this is the main evidence base that we have for ED thoracotomy. So it is based on retrospective data in the US from around a 6 year period within 2010 and 2016, with around 2012 patients. Median age of the patient was around 32, young patients, and 87% of these patients presented with signs of life. So that may not be applicable to the patient that you are seeing, but still the vast majority actually presented with signs of life. So the survival rate to discharge total was 20%. In penetrating trauma, the survival rate was 26%. In blunt trauma, the survival rate was only 7%. So in general, penetrating trauma are going to have a better prognosis if you do ED thoracotomy compared to blunt trauma. Uh, And even in penetrating injuries, the survival rate is better if it is stab injuries, 45% compared to gunshot wounds. So this is the entire data from that study. So what you need to note here is that survival rate is better if the patient was younger than 60 years compared to more than 60 years. The survival was much worse. In patients who are having blunt trauma without signs of life, which is basically your polytrauma motor vehicle accident patients, blunt trauma, they're presenting to your ED without signs of life, 0% survival. Less than 60, 0% survival. More than 60, 0% survival. That is why I said that in these patients, once you fix the reversible causes, and if you do not see cardiac activity on focus, you just call off the code, because you're not going to provide any meaningful survival by continuing resuscitation. Most of the time, the survival rate is much better with penetrating compared to blunt trauma. Even if the patient is have not having any signs of life, if there is penetrating trauma, there is still some cases who have had a good outcome. So again, this is the I'm trying to provide a practical approach about who you would select for doing an ED thoracotomy. So what do you mean by signs of life? Agonal breath. So agonal breaths on arrival to the emergency department, some kind of spontaneous movement, electrical activity on the ECG monitor or the IEPA. Pupillary reflex is present, brain check reflex is present. Any of these present would mean that patient is having some signs of life. Okay. So now we have East guidelines and West guidelines. So a lot of examiners love to ask these questions about these guidelines for how to do it, when to do ED thoracotomy. So East guidelines and West guidelines. So when you come to the East guideline, what is a strong recommendation? If the patient is not having a pulse, that is basically cardiac arrest, with signs of life, or cardiac arrest, or peri-arrest, with signs of life after a penetrating thoracic injury. For example, patient had a stab injury to the left side of the chest, right, very close to the sternum. Now in cardiac arrest. So that is a very strong recommendation for doing an ED thoracotomy. So we'll get into some of the reasons why that is when you're discussing the basic procedure about how you do the thoracotomy. But basically, that is the strongest recommendation for doing an ED thoracotomy. Conditional recommendation: pulseless without sign of life after penetrating thoracic injury, pulseless with the signs of life after penetrating extrathoracic injury, pulseless without signs of life after penetrating extrathoracic injury, or pulseless with signs of life after blunt injury. So only thing they recommend against is pulseless without signs of life after blunt injury. So as we saw here, the survival rate is 0. So they recommend against doing it there. And everything else is kind of like a conditional recommended. So it basically depends on your center. So some centers are very aggressive in how they proceed with the ED thoracotomy. So even in our center, we are probably more aggressive in how we do in whom we do ED thoracotomies compared to some of the other hospitals. So one thing you might be confused is why would you do a thoracotomy of a patient with extra thoracic injury? But I have already explained that sometimes in these kinds of patients to actually have effective compression of the heart, uh, compressing the chest wall doesn't really do much. So you need an open cardiac massage and all. That is a very conditional recommendation, not something that uh, is something that you jump to. So it has to be a joint decision with your trauma surgeon on whether you want to do this or not. What about the West guidelines? West guidelines say that this is when it becomes a headache to remember these things. So they say blunt trauma less than 10 minutes pre-hospital CPR, penetrative trauma little bit longer, 15 minutes pre-hospital CPR, or 5 minutes if it is like in a non-thoracic area, or a patient is in profound refractory shock. So if you're reading, if lots of residents just by heart these guidelines, and they end up not deriving any practical wisdom from what they're reading. So it's only when you actually go into the data behind these guidelines that you get a better idea about what they're actually trying to tell you with these. And practically what I want to emphasize is penetrating trauma, for example a stab injury, especially to the thorax. Even if the patient is in cardiac arrest, you would definitely try to push for an ED thoracotomy for that patient. Blunt trauma, you do not do ED thoracotomy unless patient arrested inside the hospital shortly after arrival in the ED, or patient has tamponade. That does happen. Even in blunt trauma, sometimes you do get cardiac tamponade, pericardial effusion. Sometimes does happen. We have seen plenty of those cases as well. So those are the situations where you want to consider ED thoracotomy in blunt trauma. So those are the basic practical approaches about how to decide which patient to do a thoracotomy in or not. Why it's important to be careful with patient selection is because ED thoracotomy is extremely resource intensive procedure. So in the moment an ED thoracotomy is started, all the staff comes in to help. You have to pump in a lot of blood products once you decided to proceed with the thoracotomy, and generally it will the whole thing will continue for a long time, so at least 20, 30, even longer than that. So if you're going to commit all of that time, energy and resources to a single patient, you have to be sure that the patient is having a somewhat good chance of a reasonable survival. So this is the basic take home for points here. Penetrating trauma, low threshold for going for thoracotomy. Blunt trauma, high threshold unless the patient had a cardiac tamponade or arrested within the ED. And generally, if you can't remember any of the all of these things, just remember that if you are see a patient had arrested pre-hospital and is coming here and your initial rhythm is PEA, you consider that patient to have signs of life. So if you're having PEA on the monitor, we consider that as having signs of life compared to asystole. If you don't remember anything else from this, but at least remember PEA. So coming to the actual thoracotomy, so you can do underlateral and or clamshell thoracotomy. So generally, these are done by the trauma surgeons at our center. In case you are in a situation where trauma surgeons are for some reason not available, and you are doing this, but you are not actually very comfortable with this, it is better to go for the clamshell thoracotomy compared to the lateral thoracotomy, because that will give you an easier access to the heart. Because main thing in thoracotomy is we are trying to fix some kind of penetrating injury to the heart, leading to some kind of hole in the heart that is leading to severe bleeding, hemorrhage, tamponade, etc. So you do vertical pedicardectomies because you don't want to cut the phrenic nerves or something. So you do vertical pedicardectomy, open up the pericardium, look for any tamponade. And if you have any cardiac lesions, it is recommended that you use your finger to actually plug the hole. Now, if you are comfortable with what you're doing, you can something similar with a Foley's catheter. But if you are not comfortable with doing, just put your hole over it, then shift the patient to the OT. So that is the how most useful thing that you can do in the acute setting from this. Now, the other things here are when patient is having something other than the heart. Then, for example, severe bleeding from the thorax, then you do something called the hilar twist and all. You cut the inferior pulmonary ligament, do the hilar twist. Generally, that is going to be too complicated for anybody who is not a trauma surgeon. And you can, if you're severe bleeding in the abdomen, fast positive, you can do you will clamp the descending aorta. In general, people do clamp the descending aorta when they do thoracotomy. So basically, even in the thoracotomy, what you're hoping for is some kind of cardiac lesion that is can be temporarily fixed. Then you shift a patient rapidly to the OT for definitive closure. We have the patients in whom we have done thoracotomies in our center, who had ended up walking out of the hospital 1 week later. They generally presented with some kind of cardiac injury. So those are the patients in which the thoracotomy can truly be a life-saving procedure. In severe polytrauma, then it becomes a little bit difficult. Then you'll have to do all of these other things and hope that the patient improves. So what are the situations where instead of the approach that I told you, you will go back to your standard ACLS approach? Patients who are having some kind of cardiac condition, the history seems like blunt cardiac trauma, then you do standard ACLS is the way to go. Asphyxiation injuries, electrical injuries, isolated injury, and brain impact apnea. So these are the situations where standard ACLS is the way to go. And of course, if the initial rhythm is VT or VF, that is another clue that you are probably not dealing with a purely traumatic cause of cardiac arrest. So what do you mean by brain impact apnea? So in patients with isolated brain injury, in the first few minutes of the head trauma, they might have apnea. So this generally lasts a few minutes, but for some patients, especially with more severe trauma and severe concussions, they can have severe apnea. They don't recur spontaneously, and this will eventually lead to death if the patient does not have resuscitation done, especially during the scene. Again, this is another reason why pre-hospital management is so important, because generally in these patients, what is essentially needed is some kind of pre-hospital oxygenation, or ventilation with the ambu bag. And generally after that, patient might start breathing again, or they might need to be intubated as well pre-hospital. In these cases, patients might have normal imaging also. So essentially, it's not a problem with bleeding or any anatomical problem, but more of a physiological problem in the brainstem leading to apnea. So that is a whole thing beyond brain impact apnea. And unfortunately, if these patients are not promptly recognized and treated, then the outcomes are very bad. So if the patients are come to you after a few hours, the patients are not going to have a good outcome. So in summary, so the approach to traumatic cardiac arrest, if you don't remember anything else from this talk, just remember that is extremely different to the medical cardiac arrest. Rapidly identify the correct the reversible causes, hypoxemia, hemorrhage control, tension pneumothorax, and tamponade. Thoracotomy, you go for it only if it is indicated, and you have to be a little bit pragmatic in withholding resuscitation in those who are quite unlikely to benefit.